So I want to thank everyone for joining us this afternoon. This is our second presentation this semester for the Women's Health Lecture Series. My name is Kayla Rogers, and I'm the Program Supervisor for the Women's Fund for Health Education and Resiliency. If you are not familiar with our organization, we're a nonprofit dedicated to providing women and girls with the tools that they need to be advocates for their health. So we do this through focused seminars like our collaboration with UHD here today, as well as curriculum-based classes and publications. Our presentations and publications are all free of charge. If you're ever interested in tuning into some of the other presentations that we have, or learning more about our organization, or ordering publications for yourself, I highly encourage that you visit our website. I've linked our publications there, and at the end, I have the link to our website as well. Before I introduce our speaker for the day, I just want to go over a few housekeeping items. So if you could please keep yourself muted to kind of limit any distractions throughout the presentation, that would be great. We will have an opportunity for question and answer at the end. So if you have questions throughout the presentation, you can definitely feel free to put those into the chat, and we will try to answer as many as we can at the conclusion of the presentation. So we're very excited to have Dr. Melanie Mazzoon back with us. She did a presentation for the lecture series last year over coronavirus vaccines. And so we thought it would be great to have her come back a year later and kind of give us an update where we are with things now. So I'm going to do a brief introduction. Dr. Mazzoon is the managing physician for immunization practices at Kelsey-Seybold Clinic. After earning her medical degree in 1982 from the University of Texas Health Sciences Center at Houston, and completing her pediatrics internship at the University of Kentucky in 1983, she returned for her residency at the University of Texas Health Sciences Center at Houston, finishing in 1985. She is a member of the Texas Pediatric Society, Houston Pediatric Association, Internal Society for Travel Medicine, the Immunization Partnership, and the American Academy of Pediatrics section on breastfeeding. Dr. Mazzoon is married with 2 grown children, and she enjoys gardening, sewing, tutoring adult study groups, and teaching children's classes. So Dr. Mazzoon, we have worked with you a few times now, and I always enjoy your presentations thoroughly. I'm so excited to have this year later kind of update, and I'm going to go ahead and turn the floor over to you at this time.
Thank you very much. Well, I hope it's not too much of a reboot of the original presentation, because I didn't know whether I was speaking to an audience that would have all heard it before, or if this was an entirely new situation. So you can go ahead and go to the first slide. I love to talk about vaccines because I think vaccines are really misunderstood by most people. We all know that we can recognize what other people do often by what kind of uniform they're wearing. You know, I'm a physician because I'm wearing this white coat. And even if I wasn't in the white coat, if you just saw the white coat, you would recognize that it was a doctor's coat. And what's interesting is that our body are non-human just by the coat that they wear. And so every virus or bacteria that infects people has a particular protein coat that is non-human. And because our bodies have this capability, they are able to develop immunity to a wide variety of germs. And so a vaccine is a protein or a combination of proteins that just mimics or is the outer coating of a virus or bacteria that we know causes serious infections. Usually the earlier vaccines that we talk about, the smallpox vaccine and polio vaccines, things like that are usually a killed or weakened germ that contains the whole outer coating, and sometimes the whole germ that's just been treated with formaldehyde or something to kill it. But newer vaccines are imitations of the germ. They are just copies of the protein coat or some portion of the protein coat without the contents of the virus or bacteria. And that's important because it's the contents that contain the DNA that allows a germ to, or a bacteria to replicate, or a virus to replicate in our bodies. And so these newer vaccines are much purer, have fewer unnecessary components, because if you kill a whole germ, you've got basically germ guts in the vaccine as well. And so if it's just a copy of the protein coat, it's a much purer and simpler vaccine and causes a much better immune response. Regardless, our vaccines give our immune systems the opportunity to recognize these proteins that are non-human, and that's in advance of being exposed to the germ itself, to the pathogen or the germ that can cause illness. So we have immunity and the ability to respond quickly if we come in contact with the real germ. Next slide, please. So everyone seems to be concerned about how we were able to come up with these vaccines so quickly. And I want to reassure you that no steps were really skipped. There are a number of very good reasons that we were able to produce these vaccines so quickly. The most important in my mind is that vaccine producers usually are self-funded, and they're not under any time pressure to make a vaccine. And making a biological medicine is a lot different than making one that's just chemical, one that doesn't have to have proteins in it. And so it's more expensive, and the manufacturers in general, before they start making a vaccine, have to decide, is this going to be worth it? We're going to have to make this huge investment up front, and we're going to have a product that may or may not produce a good immunity, and then may or may not be accepted for use by various governmental agencies or pediatric organizations or whatever the target population is. So the pandemic caused harm to many people and was harming our whole economy and our lifestyle. So the government provided funds to companies so that they could develop vaccines without any delay. And that allowed them not only to begin testing and getting volunteers and producing some vaccine for proof of concept to prove that it worked or not, but also to ramp up production so that if it did work, they would already have a supply to ship in a very short order. The steps of vaccine production have been known for a long time, including for mRNA vaccines and non-replicating viral vector vaccines, the two different kinds of vaccines we've used the most against COVID in this country. And safety studies had already been done in animal models with this type of vaccine. So it was easy to move forward pretty quickly into human studies with these types of vaccines. And also, many people volunteered to participate, including yours truly, because there were very high rates of infection, very high rates of serious outcome. So there were lots of people interested in being vaccinated, even before the vaccines were approved. And in addition, there were high rates of infection. So those of us who volunteered to be part of vaccine trials were also being exposed, and it was really easy to tell whether the group of people who get the vaccine versus the group of people who got placebo, whether the rates of infection were the same in those two populations. So there were a number of things that helped us make these vaccines and get them to the population quickly. Next slide. And I apologize for my congestion. So this comes actually from a New England Journal of Medicine article that sort of shows this graphically, where the top is the traditional paradigm, where it takes a number of years in order to even decide you want to make the vaccine, what you want to make it against, do some production of just a small amount of clinical material to do studies with, and then you start your manufacturing later once you know that there's some benefit from the vaccine, and then later on, even than that, you get large scale manufacturing once you have people who have decided that it's good for the population of their country to offer that vaccine. And so really large scale manufacturing began much earlier. Clinical development was overlapped with that. And it was very easy to pick a target for these particular vaccines because we knew right away what the new virus looked like. And there were these spike proteins sticking out on it. And they were a very obvious target for vaccines because they were the way that these viruses were entering people's cells. That spike protein fits very nicely into a receptor that's present on many, many of our cells called the ACE receptor. So we knew that that particular protein was the protein to target. So it really, really was not that any steps were skipped. We knew how to do all of these things. And in fact, was very fortunate that the government decided to back vaccine production early on and help with this process. Next slide. So, the vaccines we've heard about are, 3 or 4. And in fact, there have been lots and lots of vaccines. There are currently 117 vaccines in clinical trials and 50 in their final stages of testing. And that's as of March 2nd. And really, because almost all of these are targeting that spike protein, and that's been a very effective target, only 11 vaccines have been abandoned after trials as not being effective. So this isn't just about the expensive way to produce vaccines with the mRNA vaccines, which got to market very quickly, but also more traditional ways of producing these vaccines that are also proving to be effective. So I think that's just sort of interesting to know that there are a lot more vaccines out there than you might have heard of. Next slide. So how do we know that a vaccine is safe? Well, the best way to find out if something is safe is to test it in large numbers of people and watch them to see if they have any bad outcomes. That's also the best way to see if it's effective, is to test them in large numbers of people and see, are the people protected? So bad outcomes happen to people all the time. We all know somebody who might recently have had a heart attack or a stroke or a car accident or whatever. Bad things happen to people, and they happen rather randomly. So the larger your treatment and control groups are, the more you can differentiate between whether your intervention, in this case your vaccine, caused a bad outcome or not. And so individual experiences with bad outcomes need to be reported and they need to be checked out, but they shouldn't be accepted as being caused by the vaccine until they're investigated. A lot of the people being immunized are going to get a cancer diagnosis or, have a car accident. You would more likely want to blame the cancer diagnosis because it seems more medical than the car accident. But in fact, both of those things are likely to be random occurrences after vaccination than actually caused by the vaccine. Next slide. So they need to be investigated. And the government did a very good thing. They said they developed this app called vSafe, which allows people to easily submit any bad outcomes through their smartphone into a system called VAERS. VAERS is the Vaccine Adverse Event Reporting System. And it's basically a catch-all for reporting for anything that anyone thinks might be caused by a vaccine. There are other vaccine safety surveillance systems as well. In the US, we have the Vaccine Safety Data Link, which is basically a collection of data from electronic health records from people who are in large systems, such as Kelsey-Seybold, but we're not actually part of Vaccine Safety Data Link. Kaiser Permanente is the biggest contributor to this system, but these large healthcare systems that report their healthcare data, de-identified, but their data, so they can say, we had, 10 people who developed, some outcome given, just pick an outcome after getting vaccines within 2 weeks, but that's out of a population of 600,000, for example. And then you can determine, well, is that a rate that's higher than in the general population or not? Not only that, there are other tracking systems in other countries, and many other countries have nationalized healthcare systems where they have the data on their entire population to know about health outcomes that occurred after vaccination. So all of those are being monitored for unexpected outcomes. VAERS, our system, accepts all reports, most of which are going to be concerning outcomes because people don't report anything that's, they don't report, hey, I was fine. I didn't have any problems. The vSafe app does check with people and ask them repeatedly, are you having any problems? Are you having any symptoms? And they can report even if they have like mild symptoms they otherwise might not thought of reporting. But in general, people don't report that nothing bad happened. There's no denominator for the number of doses of vaccine that have been given in the VAERS system. And there's no proof that the vaccine, there's no requirement that you have to prove that the vaccine caused the outcome in order to report it. And the whole idea is to encourage reporting. So there's also no way when you do a report to check and see if that bad outcome has already been reported by someone else. So go ahead and to the next slide. So the government actually required that we report all deaths. All physicians and doctors and hospitals all report all deaths after the vaccine. So sometimes things will be reported by more than one healthcare provider. It's very important to know that a lot of the misinformation circulated on social media consists actually of the misuse of this VAERS system data set. Although the VAERS system states clearly that the data can't be used to determine causality. And I'll explain that a little bit clearer in a minute. Because we report all deaths and all suspected adverse events, then the death might be reported by your family doctor, it might be reported by the doctor in the hospital, it might be reported by the nurse in the hospital. It can be reported by several people. And this over-reporting is encouraged in order that we don't miss any possible bad outcomes, because we want the system to be very sensitive to any bad outcomes. Also, many things associated in time, which I touched on before, are not necessarily caused by the vaccine. The age group that had the highest vaccination rates currently, and also was the earliest to be vaccinated, is those age 75 and higher. And so people who are over 75 die at higher rates than people who are under 75, as you might imagine. So, and they also come down with cancer diagnoses and strokes and heart attacks more often than younger populations. So you have to recognize that they're going to have a lot more randomly associated bad events in association with the vaccine. So every one of these reports is then investigated, particularly serious reports like death or stroke or, the clotting system problems that you may have heard were caused by the vaccine. So each report is investigated thoroughly to determine if those reactions were caused by the vaccine. Next slide. So this is basically like telling a group of children to put, all the oranges in a bowl, and they might pick up, orange balls. They might pick up only oranges. They might pick up tangerines or grapefruit. So in this bowl, for example, of quote unquote oranges, there are at least 3 items in there that are not oranges, but actually there are like 1, 2, 3, 4, 5, 6 of those are tangerines. One's a grapefruit, and only 2 of those are oranges that you can see, not even mentioning the plastic apple. So that's the same thing that happens with the VAERS system. Everybody throws in anything they think might be in the category of a vaccine adverse event. And then somebody has to go through who has more expertise to actually, discard things that are not likely to be associated with the vaccine. For example, car accident deaths or, a variety of things. People who died from an illness they had before they even got the vaccine, for example. Next slide. So a lot of times people have a question about this at messenger RNA. We can start talking scientific terms, it scares people, but messenger RNA is actually like a little stencil. So your DNA is in your cell nucleus, and it encodes information for all the proteins in your body, but it doesn't actually make the protein. The messenger RNA is actually a messenger to tell the rest of the cellular machinery outside of the nucleus what kind of protein that cell needs to make. So messenger RNA, when the DNA kind of opens up, the messenger RNA will take an imprint or a stencil from that portion that's opened up, and then it will move out of the nucleus into the cytoplasm and tell other cell organelles like Golgi bodies to make the proteins that our body needs to be made. So we are all made out of a lot of different proteins. I know everybody knows you're 75% water, but you're also a lot of protein. And some of those proteins you might have heard of, keratin, people talk about for their hair products, and hemoglobin and myelin for your muscles, and myelin for your nerves, and myoglobin. All of those proteins are essential to the function of our body. So our cells are little protein manufacturers, and those proteins are very specifically made. And when that process goes awry, we might have a disease even. For example, if your hemoglobin isn't made properly, you might have sickle cell disease or thalassemia. So messenger RNA vaccines take advantage of this normal process by introducing the mRNA for an important surface protein, the spike protein from the virus, that the cell then makes using its normal process. So the good thing about messenger RNA, and you can go on to the next slide, the good thing about messenger RNA is that it's a very short-lived, fragile molecule. If messenger RNA hung around very long, you'd make way too much keratin and you'd become a big giant wart, or you'd make way too much hemoglobin and you'd have, really sludgy blood because it would be way too thick. And so messenger RNA degrades rapidly, and the cell stops making whatever the protein is that it was instructed to make very quickly. So the messenger RNA that codes for the spike protein is taken up by cells that produce it and put it on their surface. And then those cells that have it on their surface migrate to a local lymph node where the immune system says, hey, that's not a human protein. We need to get rid of that. And the lymph node systems then make B cells and T cells to make antibodies and to kill the virus infected cells in the future. So that's two different kinds of immunity that are developed by this, by using this messenger RNA type of vaccine. So these antibodies, which are sort of an immediately produced protein that sort of floats around in your bloodstream, those attach to the spike proteins on a virus or on these cells that have put it on their surface, and they tape over that protein. They mask it in a way, and that little bit of tape or that antibody then tells your white blood cells to gobble up that foreign protein and to get rid of it, and your spleen then gets it out of your system. So that's a kind of simplified way, but if you think of antibodies like a little piece of tape over that spike protein, those continue to float around long after you got your vaccine and long after that messenger RNA is gone. And even at low levels, once you're exposed to the virus, they will attack the virus early on. And they will also at that point stimulate the T cells to make more antibodies to kill any ones that got past that initial wave of antibody protection and started replicating in your body. Next slide. So the other type of vaccine, which we're no longer using much of in the United States, is the viral vector vaccine. And that's both the Janssen and the AstraZeneca vaccines are non-replicating viral vectors. And those are a different way of getting your body to produce the spike protein. The viral vector is a common virus called an adenovirus that's been modified so it can't reproduce itself, but it still can get the instructions for making the spike protein into one of your cells or several of your cells so that they can then make the spike protein. The viral vectors last longer in your arm than the messenger RNA. They don't degrade as quickly, and they usually stay around for about 2 weeks. And so initially the Janssen vaccine was a one-dose vaccine because you would be making that spike protein for a while, for like 2 weeks instead of just a few days after your vaccine. And it was thought that that would provide long-term immunity. But now we know that it doesn't provide much longer immunity than the mRNA vaccines. So now you're recommended to also get an additional dose of that vaccine or of a messenger RNA vaccine, since we're no longer using much of the Janssen vaccine. Both the Janssen and the AstraZeneca vaccines had more side effects than the messenger RNA vaccines. And this is actually a tribute to the VAERS system for its ability to pick up rare adverse events. So in the case of we didn't use the AstraZeneca vaccine. So those rare adverse events were picked up in England, to be clear. But clotting issues, primarily in women under the age of 60, were picked up very early on as an adverse event of concern that needed to be investigated and was found to be determined to be due to the vaccine. And those have not been very common. So there have been about 57 cases of this thrombocytopenia with thrombosis syndrome, TTS syndrome, caused by the Janssen vaccine. So that's not 57 cases out of, like 500 million doses of the vaccine having been given, 550 million doses having been given so far. That's not very many cases. So it's a testament to the sensitivity of the VAERS system. And more recently, there have been cases of Guillain-Barré syndrome also associated with these viral vector vaccines. And for that reason, we're no longer using or recommending the Janssen vaccine for most people in the United States. It still has an EUA. It still can be used. If you got it and you didn't have any of the side effects that I'm mentioning, you don't need to worry about that. You didn't get it, you're past that point, because basically we're using the messenger RNA vaccines to boost those people now. And so if you got through the very first round, those are very, very rare side effects. There have been about 330 cases of Guillain-Barré syndrome, and as I said, about 60 of the thrombocytopenia syndrome out of these 550,000 doses of vaccine, and they're not associated with the other, with the messenger RNA vaccines. Next slide. Okay, so is it worth getting vaccinated? Well, first of all, let's show what COVID has done to us. So I can't point on the slide, unfortunately, but if you look to the left, you'll see, well, first of all, the whole slide, you'll see these alternating lavender bands are years or flu season years. So they're basically from, fall through spring. Well, they're midsummer through midsummer. For 1 year after another. And that wavy black line is sort of the baseline rate of flu and influenza. So you can see that every winter we have a little bump up. We have cases of flu and pneumonia. And then every summer and spring it goes down. And so it's a wavy line at the bottom. Occasionally we'll have a bad flu season. So this red line is actually the number of cases of all, or percentage of all deaths due to pneumonia, influenza, and COVID-19. So it's a national summary for year over year. So in 2017, 2018, that winter, we actually had a really bad flu season. So you'll see that bump in the red line. And also down below, you'll see the kind of orange mountain there. That's deaths that were coded as being due to influenza. So then if you look at the next year, 2018, 2019, you'll see, well, the red line pretty much followed the black curve. So pretty standard season. Still, there were a bunch of deaths due to influenza. So there's little blips or deaths due to influenza. Every winter we have, 35,000 deaths due to influenza. So it's actually a vaccine preventable disease that before COVID was the most common preventable cause of death by vaccines in the United States. And then the following year is when COVID began. So you can see we were having a pretty average flu season, maybe a little more death than we thought. Maybe some of those deaths were actually coded as influenza, but were early COVID deaths before we really knew what we were seeing. But then all of a sudden you get this huge rise in the red line, way above bad flu seasons. So when people tell you that it's a manufactured illness and that we're just, spitting out numbers, this is what reality is. We had a horrible rise with the initial wave of COVID in 2019, 2020. Then it started to taper off. And that tapering off was not due to vaccines. That was due to, masking and protection measures and the fact that we weren't visiting people in nursing homes, that kind of thing. And then another rise as it started to go through the population more generally. So that first peak is, a lot of nursing home deaths, a lot of the elderly, unprotected people. And then I wish they had the little vaccine on here. So the vaccine came around week 56. So as you see that the third peak start to go up, we got vaccines in December, or 52, I should say, not 56. They're only 52 weeks in a year. So we started to get vaccines as you see this next big peak go up. And then we had a really bad winter. And then we all felt really good in the summer, like things were going down and things were going to get better. And then we had the Delta wave. And this doesn't really show the Omicron wave, this particular slide. So you can see it went down, but then it's going up again. That's the Omicron wave. Next slide. Lots of deaths due to that. So I just want to give you kind of an overview. So currently, and these are more estimates, I had kind of tried to keep this accurate, but the numbers keep changing so rapidly. So currently about 75% of the US population is vaccinated. About 25% remains totally unvaccinated. And by vaccinated, I mean 2 doses with or without a booster. And so I just want to give you a graphic picture of like what we're looking at. So the deaths due to COVID are about 900,000. They're really more than that at this point. But again, early on, we didn't know if deaths were from flu or COVID. And there's still a lot of deaths that it's probably underreported as being from COVID because people may have caught their COVID and then started to improve and then later had a stroke, for example, due to the clotting effects of the COVID virus on those ACE receptors I talked about earlier. So inside the white virus, that's deaths. That red line is supposed to, demarcate if you're vaccinated or not. So there's a little bit of white outside there, but basically most of the deaths from COVID among the unvaccinated were due to either a poor immune response to the vaccine or getting the vaccine very soon before they caught the COVID so that it didn't have complete effect. Because remember, you aren't immune until 2 weeks after your second dose. And most of the deaths from COVID have been among the unvaccinated, and that includes the unvaccinated prior to the development of the vaccines. The purple is, hospitalizations. So yes, some people who are vaccinated are going to be hospitalized, but the majority of people who are vaccinated majority of hospitalizations are among the unvaccinated, despite the fact that the majority of people are vaccinated. And the majority of cases overall are, again, among the unvaccinated, either before vaccines were available or people who have some sort of reason that they are still susceptible. So one reason for that is this Omicron and the Delta variants are both more contagious and infected people who were vaccinated, but that was mostly mild illness. On the other hand, this little circle over here at the left is just to represent hospitalizations and deaths due to the vaccine. So you'll hear a lot of social media about how dangerous the vaccine is, but there have been fewer than 2,000 hospitalizations, and that includes, basically less than 1,500 cases of myocarditis and all the group B streps. All the Guillain-Barré syndromes and all the thrombocytopenia, and clotting issues. So there've been, all of that put together is still less than 2,000 people and fewer than 100 deaths attributable to the vaccine. Not that that's trivial. 100 deaths attributable to the vaccine is scary, but actually that's an overestimate too. So it's a very small amount and much less scary than staying unvaccinated is the point of this slide. Next slide. I apologize for my voice. I'm fighting a sinus infection from babysitting my grandkids. So the vaccines are effective, as shown in that slide. The variants have changed the shape of the spike protein, so that little piece of tape of that antibody doesn't necessarily fit it as tightly, but the immune system is still primed to respond more quickly and effectively, even if you're infected, if you get the vaccine. So that's why people who are vaccinated get milder or even asymptomatic infections. All of the vaccines, including the Janssen vaccine, are very effective at preventing hospitalization or death, though people with immune system compromises and the very old are still at some risk because their immune systems are not as vigorous and they're not able to develop the immunity as well with the vaccine. And as I said, vaccinated people who don't have immune compromise or other conditions that predispose them to illness are having mild infections even when they do get infected. Next slide. This is this slide shows the Omicron wave. So these are age-adjusted rates of hospitalizations by vaccination status. So you see this green line, that's vaccinated people and how many per 100,000 are hospitalized. So fewer than 10 people out of 100,000 who've been vaccinated are hospitalized, and really closer to under 5, except with the Delta wave starting in the fall of 2021 and the Omicron wave. Oh no, this only goes till 11/20/21. So this actually doesn't include the Omicron wave. This might be, this far right might be it starting to go up again. While unvaccinated people are getting, much higher rates, up to 70 to 80 per 100,000. Next slide. This one shows the Omicron wave. So you can see, I want you to notice that on the side, that last slide went up to 80 per 100,000. This one, they've actually increased the scale, or actually reduced the scale, so that little up and down was over here, was in November, the down and starting to go up. If you look down at the bottom, you can look for November 6th. That's where that was starting to go up again. So they had to change the scale to show the hospitalizations from the Omicron wave. So that shows how much of the population really got infected. So really large numbers of the population got infected. And that has turned out to be a good thing. Next slide. It's not good for the people who got infected, but it's been a good thing for our immunity. So, oh, I'm sorry, I forgot this slide was next. I'll talk about the good thing in a second. So these mutations basically, again, affect the fit of the antibodies to the protein. And I want you to think about it like a key and a lock. So if the spike protein is the key and it fits into the ACE receptor on our cells, which is the lock, that basically allows the virus to enter the cells. It turns the key in the lock and it enters the cells and it makes the cells reproduce viral particles, including their DNA and everything. So if the key changes to fit the lock better, for one thing, it doesn't fall out of the lock, and it turns it faster. So that's what makes that shape change is actually what makes the Omicron variant more infective, and basically makes it more transmissible, because it takes fewer of these viruses to actually be effective at infecting a person. And because once it infects people, it reproduces in very high numbers because more of them are staying locked to the cell, then that person is producing more virus to spread it to other people. So that just that simple change in the protein increases both the infectiousness and the likelihood that you'll get sick from the virus. Fortunately, again, the virus hasn't mutated away from our current vaccines, but the good news is that the mRNA vaccines can be easily modified to the new protein. So if we need an Omicron vaccine, we can actually make one that's to the Omicron spike protein, which is a slight variation from the original one. Next slide. And there still could be new mutations, but so I wanted to talk just a little bit about why the vaccination schedule is changed, and just to let you know. So for most people, you want 2 doses in your primary series, regardless of what vaccine you get. The Janssen vaccine, that's still considered a 1-dose primary series. And then for those over the age of 12, we're all now recommended to get booster doses, including those who got the Janssen vaccine. The Janssen vaccine, you can be boosted as early as 2 months. I kind of think that's just because for some reason they don't want to say you need a second dose in your primary series, because they're not offering a 3rd dose to those people, just a second dose. Whereas the mRNA vaccines, you need to have your 2 doses in your primary series, 3 to 8 weeks apart. And then you need to have your booster dose after about 5 months. So this 3 to 8 weeks is a new change. It's only going to affect people who are just now starting to get their vaccine, but there is some evidence that a longer interval between the first and second dose actually may increase your immune protection. So you'll recall that the Pfizer was 3 weeks apart for the series to begin with, and the Moderna 4 weeks. But there's now evidence that if you wait a little longer, if you delay getting that second shot, you'll have longer lasting immunity. However, you're still going to be vulnerable because you won't have gotten 2 doses, and being 2 weeks after your second dose, you'll still be vulnerable to infection in that period of time. So that's a discussion between the individual and their doctor about what's best in their circumstance. If they're immune compromised, if they're about to get cancer chemotherapy or something like that, it probably is better to stick to the original interval. If they're a healthy young adult and not out in the public very much, then the longer interval may be better. And then everybody should get boosted. Originally, they were saying 6 months. Now they're saying 5 months or more. Next slide. And then the immune compromised, people with immune system compromise, get 3 primary doses. We know now that it's safe and effective in pregnant women, and that pregnant women are at high risk of serious illness with COVID virus. And we also know that it's safe in breastfeeding women, and that it produces immunity that can be transferred not only through the placenta during the pregnancy, but through the breast milk to the baby, and that babies who are breastfed are less likely to catch COVID as well if mother's been vaccinated. So we encourage pregnant women to get vaccinated if they've not been vaccinated. It's not something that women should worry about. They should get vaccinated. Someone is asking a very good question there about foreseeing needing a COVID vaccine yearly. And I think that's going to really depend on how long this virus hangs around infecting all of us. And I'll go into that in a minute, but I just saw that question pop up, and it's such a good question. So some people wonder if, they already have clotting problems, do they need to worry about the vaccine or worry more about COVID? COVID, because it attaches to that ACE receptor, actually causes a lot of clotting problems. You probably heard of COVID toes, where your toes turn purple, and it also is associated with strokes and heart attacks. So the vaccine is much safer than getting ill with COVID. And really, there's not been any increased incidence of problems, including that thrombocytopenia with thrombosis, TTS syndrome. That's not been increased in people who have any history of anticoagulant use or any history of deep venous thrombosis or It's not increased in women who are pregnant or have other predisposing conditions either. So next slide. Okay, so I thought I had this right after the other one, but basically, if you are immune compromised, you need to get 3 doses of the Pfizer or of the Moderna vaccine. And they now have a very specific schedule for doing that. And you need to get the booster dose. So that's the difference. And people who are immune compromised are, people who have AIDS, people who have, who are on cancer chemotherapy, people who lack a spleen, people who have, lymphoma or other blood organ cancers. Sometimes people are on medications such as oral steroids over a long period of time. All of those things that compromise your immune system mean you need extra doses because it dampens your immune system's response. Next slide. I just want to briefly touch, we early on, we worried about allergies and anaphylaxis. This really is a manageable problem. It doesn't occur very often, but if you're at increased risk, we want to watch you for 30 minutes after your vaccine. People who recently had COVID vaccine and were treated with antibodies, we were waiting 90 days after treatment before they could be vaccinated, but now we know we don't need to do that. They can be vaccinated sooner. People who've had dermal fillers, like cosmetic fillers around their lips or whatever, sometimes will have a local reaction in the area, particularly with the mRNA vaccines. And that can last several days. And that's related also to that PEG component of the vaccine. And people who are currently isolating or symptomatic with COVID-19 basically should wait until they're not symptomatic and not contagious before they go into some place to get vaccinated so that they don't infect other people. Next slide. Okay, everybody knows you're going to get fever and a headache and muscle aches, and that most of you have either had the vaccine or had a friend who had the vaccine. Soreness and redness at the site is pretty common. What's more common with this vaccine than with many other vaccines is to get swollen glands in your armpit, which can last several weeks and maybe even a couple months if it can be detectable by mammography. So our mammography center, for example, at Kelsey, actually recommends that if you need a screening mammogram, get it before you're vaccinated or wait until 2 months after your vaccine, because swollen lymph nodes in your armpit can also be present if you have something wrong with your breasts, like a breast cancer. And so just to reduce unnecessary testing, it's best to either get your screening mammography before getting vaccinated or 2 months later, so the swollen glands will be gone and not cause you to have to get other testing. Let's see. And then, side effects that might indicate a serious problem would be a severe headache or small red dots over the skin. Those could be indications of that TTS syndrome. But again, that's only with the Janssen vaccine, which we're not recommending for people anymore. Abdominal pain and chest pain. The chest pain, the myocarditis is actually pretty mild and is a problem mostly for teenage men up until about age 30. It's actually been shown that the vast majority of cases recover with a little bit of ibuprofen or non-steroidal anti-inflammatory medications. Early on, they hospitalized a lot of those people. They do have abnormal levels of something called troponin, but really the vast majority of people recover in a few days with just ibuprofen. So if you have chest pain following the vaccine, take some ibuprofen, and if it persists, check with your doctor. And then the neurologic symptoms also refer to that TTS issue, but these are all, again, very, very rare. And then the other neurologic symptoms that would be with Guillain-Barré syndrome would be weakness in your extremities and it progressing, like you feel weak and then you feel weaker the next day. That would be something to be concerned about. Next slide. And Guillain-Barré syndrome, while it is quite serious, is something people can be supported through and recover from. It's not often a cause of death. Once you're vaccinated, are you at risk to others? You've all probably heard the social media memes about things like changing people's menstrual cycles and fertility issues and all kinds of things. These are not live viruses. There's no way you're going to spread any vaccine protection or any vaccine component to anybody else. So there's nothing that's going to leave your body and spread to anyone else. It's unlikely that you'll shed much virus even if you're infected, but we do know that you can have an asymptomatic Omicron infection and spread a little bit of Omicron virus, but less than an unvaccinated person. There's no effects of a vaccinated person on the menstrual cycle or fertility of others, or on the fertility or pregnancy outcomes of the vaccinated person. But we do know that just as other stressors can make your menstrual cycle vary by a day or two, the vaccine can actually make your cycle vary by a day or two, coming late or early, with resumption of normal cycles later. And so that's something that's been demonstrated fairly recently and did cause some alarm among people. But, you know, I think most of us women have had cycles that were a day or two late here or there when we got sick with something, or when we had a stressful event in our life, such as, you know, a divorce or death of a family member, or just, you know, tests coming up in college or whatever. So that it's that same kind of temporary variation. Next slide. So the original estimate was to control that original COVID-19, which was not as infectious as Omicron, that we'd have to have 7 or 8 out of every 10 people need to be immune. And the US population is more than 330 million people. We've given about 550 million doses of vaccine out. So we actually already have about 250 million people immune from vaccine. And we have an awful lot of unvaccinated people who are immune from Omicron. So the good news is I think we have reached pretty much that herd immunity effect. So if we looked back at that earlier slide, you saw that drop off in infection. That's because our population is now nearing herd immunity, or protection based on the whole population being immune to the virus. The early on estimates were that if we had to rely on infections alone without vaccines, between 1 million and 5.4 million people would die. And we are right at about 1 million people now. With Omicron being more infectious, more contagious, and more just as serious among the unvaccinated, you know, we can thank the vaccines for the fact that we haven't needed 5.4 million people to die. 1 million is bad enough. And so that's really, I think, a testimony to the effectiveness of vaccines, that we haven't gotten to that 5.4 million. I think with the Omicron mutation, we surely would have gotten there because of its contagiousness and seriousness, and the Delta wave as well. So next slide. So this is close to being all over, which is really good news. So boosting is also occurring. So the vaccinated people who catch Omicron and have a mild or asymptomatic infection, that actually boosts your immunity, exposes you to that change in the spike protein. It's actually given you an Omicron vaccination, as it were. So part of the answer to the earlier question about whether we're going to need annual vaccines really depends on how much this virus continues to circulate and how well our vaccines continue to protect. So it's going to depend on whether there are more variants to come. And the fact that we have so much population immunity means that the virus is not circulating to as many people, and it's infecting fewer people. And that's going to reduce the rate at which new variations become widespread. And so that's really good news because Omicron may provide cross protection to new variants for a while. And so we're likely to see a rapid waning of the pandemic, even in countries where vaccines are not widely available. But unfortunately, that's going to be at the cost of a high number of deaths in those countries. What's likely to happen is that Omicron is likely to become a disease of the young. So now we can vaccinate from age 5 and up. And we have vaccine studies ongoing that are not proving to be terribly effective for 6 months through 5 years. So what's likely to happen is that the virus will continue to circulate in our young. And so it will become important to get a vaccine that is effective for 6 months to 5 years. Because while that population doesn't have a lot of serious outcomes from any of the coronavirus infections so far, we do have deaths. We do have hospitalizations with this multi-system inflammatory syndrome that make kids really ill. And while the adults have all, either gotten vaccinated or gotten Omicron and will be protected, the young, have been largely protected. They're at home. They're either newly born, they're protected while they're breastfed. Then they become vulnerable as that immunity wanes and they're no longer breastfed. They'll go through a period of time, where they're not exposed to other kids. Perhaps they're not in daycare or they're not in a large family, but then they will be exposed to other kids. And when they hit that exposure threshold at daycare or preschool or whatever, they're likely to get infected because this virus is not likely to completely go away. We have this pretty large population of vulnerable people still existing. So my thought is that, it's going to stop killing a lot of people. It will still be an infection of concern, particularly in the young, and new variants and how much infection occurs in young will really determine whether we need to be vaccinated annually, boosted, or whether we need to really be pressing for vaccination in children more than we have up till now. So someone asked that I repeat what I said about an asymptomatic person that got COVID. So if you were asymptomatic and you got COVID, your immune system still was exposed to that Omicron or that COVID vaccine spike protein. So your immune system responded to that. And the fact that you were asymptomatic could be because you got a very low dose of virus exposure and your immune system responded pretty quickly, or it could be that you were previously vaccinated and that's why your immune system responded quickly and kept you from having symptoms. So any exposure, whether it's to the vaccine or to the coronavirus, is stimulating your immune system. And as long as there's some Omicron or any other variant of the coronavirus circulating, then you're going to have exposures that boost your immunity. Remember that the coronavirus is actually in the family of the cold viruses. The reason that we've never been able to produce a vaccine against the common cold is that there are hundreds of coronaviruses. And so every cold we get is not the same virus, it's a different virus. Most of those viruses are fairly mild and cause few symptoms, but enough to make us miserable, but not enough to keep us out of work generally, for example. And those coronavirus, the thought is that with a little luck, this virus will mutate to be more like a cold virus and be of less concern. But we know that it fits that ACE receptor, which most coronaviruses don't do. And that ACE receptor is where your seriousness comes in for this infection. So, a lot is going to depend on variations and whether they fit that ACE receptor better or worse. They're likely, the biology is that it reproduces better if it fits that receptor better. So the likelihood is that we'll continue to have this coronavirus circulating and causing serious illness, at least in the young, because it fits that ACE receptor very well, and because that's the cause of most of the serious complications. But overall, for the population, it's likely that things will be much better by the summer. I'm hopeful. There was some talk about the vaccine for younger children being approved, and that was put off. That was put off because they know that 2 doses are not enough and that most kids are likely to need 3. Part of the reason for that is they chose to make it, excuse me, even a smaller dose than are given to 5 to 12-year-olds. So I think they're trying to determine, do we need a bigger dose and 2 doses, or do we need to stay with the smaller dose and give 3 vaccinations for immunity in the younger? You remember, most kids who are under a year need a series of 3 shots of almost all of our vaccines in order to be protected, because their immune system, just requires that much to be stimulated. And sometimes they need a booster 6 months later. And so all of that is still being studied. But I do think that once vaccines are available for kids 6 months to 5 years, that we should be giving them. And the reason is that I think this is going to continue to be an illness of the young, even if it goes away in most of the current adults. Those who are recently born or continuing to be born are going to come out vulnerable and will need to be protected, because I think the virus will have enough of a population to continue circulating. Next slide. So the vaccine won't work for everyone, especially not for people who can't get it. And we don't know how long protection is going to last, because we don't have enough years in this pandemic to know. We don't have any studies of people 5 years out from vaccination. Do they still have immunity? So we really don't know about future protection until we get to the future. Those who know they're vulnerable, those who are very elderly or know they have immune system compromise, should continue to mask. And we need to, as a community, support those people and not make them feel like they are, outcasts or stupid for continuing to mask, as others among us are able to go around without masks. I think that period of time is coming upon us. I think by the summer, clearly, a lot of the mask mandates have gone away, and in schools, kids are unmasked now in many school districts. But I think masks are going to be with us for a long time for those who know that they're vulnerable, who they are pretty sure the vaccine may not have worked for example, those with AIDS or who are at a high risk of pneumonia for reasons of, COPD or whatever. I think that all of us should consider masking when we're at large indoor venues for a while longer, until we really see this drop off. The rodeo is a good example. There are outdoor areas where it probably isn't necessary to mask, but if you're sitting packed in the stands next to a whole bunch of other people indoors, that's probably a good time to wear your mask. Not only to protect yourself, but to protect those who are unable to be vaccinated, to protect the young, and to protect those at higher risk. Next slide. I think we are going to continue to see that curve go down, and that we are going to be able to lose the mask. And I think it's going to be fairly soon, but I think we should be watching those local factors. So there's still some parts of the country where, a large percentage of the population is not vaccinated, up to 50% are unvaccinated. Those areas are going to continue to have this pandemic longer than areas where a large percentage of people are vaccinated. Healthcare systems are going to continue to request people be masked when they come to appointments for a while now, because you're in close proximity to your physician. Your medical staff can transmit it from one patient to another. We're dealing with people who are immune compromised. There are just going to be a lot of little variables that keep us wearing masks in particular situations. When you get a cold, you're not going to know if it's Omicron or not. You know, you're going to probably mask when you go to work if you have a runny nose. I have this sinus infection. I know I'm Omicron. I mean, I know I'm COVID negative, but I'm wearing a mask. But then I'm also in a healthcare system. But I'm wearing a mask everywhere I go because I think people will be a little suspicious of people who have a raspy voice like mine is today or sniffles. So I think that the masks are going to be around us, with us for a while. If you know you've had close unmasked contact with someone who has had COVID, you should get tested about 3 days later, even if you don't have symptoms, or, you know, avoid contact with people that you know are vulnerable for at least 5 days. I think that that's the current advice. I think with this big drop off, fewer and fewer people are following the advice because I think we're all relaxing, but I think, you know, we're relaxing maybe a little bit early. I think we're all anticipating a big relaxing of this, but remember, we still have all those kids who are vulnerable and all those people who are elderly who are still vulnerable. So don't relax too much. So next slide. This is actually a CDC infographic that just is encouraging people. There are a lot of people who had COVID who say, well, then I don't need to be vaccinated. But we know that the infection itself doesn't seem to produce very long-lived immunity, that people can get COVID more than once. And it's safer to get a vaccine as your second exposure if you had COVID already. So if you've already had COVID and you've been avoiding vaccinations, you should get at least 1 dose, and really you should get 2 doses. And that would put you up with those who got 2 doses in an original series and a booster. So go ahead and get vaccinated. It helps to protect you from serious illness, particularly since variations, you may not know what variant you've got, and variations have come along multiple times. Next slide. So when should you get vaccinated? Now, clearly. Now, or you probably already have for most of this audience. And I'm ready for questions. Next slide. So I'm going to open the chat and go up to the top. Okay. I'm interested to see that the VSafe didn't let you report when you were overseas, because I thought that it's a telephone app that you could report from anywhere, but it was a US app, and it was designed to report into our system. So it may be that because you were overseas, they didn't want to count you in our system and wanted you to be counted in whatever country you were in. I don't know the answer to that. Be interested to find out or get a little more info. Pink oranges, okay. So how about a COVID vaccine yearly? You know, I would love to see a combination COVID booster with flu vaccine if that happens. What will first have to happen is we'll have to determine, do we need it yearly? I think, so the interesting thing about vaccines is it depends a little bit on what your community exposure is. So the MMR vaccine, when it first came out, they said you only needed 1 lifetime dose because it provided lifetime immunity. But with measles being so contagious, what probably was happening was it provided you good immunity, and then you kept getting boosted by other people in your community having measles until the rate of vaccination went so high that the rate of measles went so low that you were no longer being boosted by exposure in your community. And then we found out you needed 2 doses of MMR vaccine. And even 2 doses only gives you about 98% protection, not 100% protection. So we're in that same sort of scenario now where, you know, those of us who are vaccinated are pretty well immune, but we're getting boosted by probably at least weekly contact with somebody who is shedding COVID and doesn't know it because they're asymptomatic. And so that exposure, frequent exposure, is boosting us and keeping us good. So I don't think we're going to need a COVID booster. And this is a change from what I might have said at an earlier webinar. COVID really changed a lot of things. So I don't think we're going to need Omicron changed everything. So I don't really think we're going to need a yearly booster unless we get a significant change in the variant that the vaccine no longer covers. The manufacturers of the mRNA vaccines are already producing, some testing material of, Omicron boosters, for example. But there's been no reason to have them even approach the FDA for licensure because the current vaccines are still protecting people against Omicron. So it's really going to be a matter of how does the virus try to evade us in the future? I think it might be that we need a booster every 5 years. It might be a thing that we don't need a booster at all if we can get a vaccine down to our youngest kids, because the amount of circulating virus will be so low that it doesn't mutate very often, because it needs a large population to do a lot of mutating. I think we really don't know. I wish we did. Someone had COVID for the second time in a 90-day period. And when can they get their booster? So you can get a booster. Basically, I would say that you could get it anytime. You don't tell me if you've been vaccinated. So if you've been vaccinated and it's been 5 months, you can get a booster, regardless of the timing of your COVID. But to have had COVID twice without a vaccine, I think you should probably wait a month and then get a dose of vaccine, and really probably get another dose like 2 months later. Follow that 8-week interval, because that provides more immunity. So if you don't have any vaccine, I would get your first dose a month after your COVID, and your second dose 2 months later, 8 weeks later. Is it safe to get a different vaccine from the first dose? And the answer to that is yes. We do think that if you got an mRNA vaccine for your first dose, you should get the same brand for your second dose. So if you got Moderna, get Moderna again. And then you can choose a different one for your booster if you would like. But we're actually recommending that people who got the J&J vaccine get an mRNA booster rather than a J&J vaccine, because of the side effects from the J&J vaccines. It is certainly safe to get the different vaccine, but what most of the studies have been done on people who got the same vaccine for the first and the second dose. So the real answer to your question is we don't know. We know it's safe, but we don't know how effective it is to get, a Pfizer followed by a Moderna, or a Moderna followed by a Pfizer. And we do know it's effective to get the same brand, for the first and second dose. So ideally, you'd get the same brand. If you don't have that option, it's fine to get the other brand. I think I already answered that one. Next one is, aren't we discontinuing the use of masks too soon? And I think the answer to that is yes. But there's an awful lot of social pressure to discontinue the use of masks. So in the pediatric and school population, the pressure is because, kids really it's interfering with their socialization, although you'll hear some teachers say they don't think so and others think they do. It can interfere with acquisition of speech in toddlers because they're not seeing your mouth move. We need our kids in school, and the AAP position is that masks are safe and effective, and we should continue using them at present until local rates go down. But local rates vary quite a lot. So, in California, where they had wider spread vaccine and mask mandates, the rates are lower than rural Texas, for example. So it's really a local decision about where, where we discontinue masks, when we discontinue masks. Again, the Omicron has vaccinated, quote unquote, a lot of people who are anti-vaccine. So I think the time is coming, but I think it's summertime that we're going to be safe to discontinue masks. Why are 2 to 3 year olds required to wear a mask? Well, so here's the deal about toddlers. They are really just cesspools for all kinds of human infections, especially respiratory and GI infections. I hate to say that. I have 2 toddlers, young infants and toddlers in my grandchild bag of my own. But, it's entry to preschool is when kids start getting really sick, and they usually get sick twice a month. And it's because toddlers have no hygiene. They slime everything when they have a cold. The reason I have this cold is because my 7-month-old grandson coughed it right in my face as I was diapering him, and it's just really hard to prevent infection in that age range. You're absolutely right. It's hard for them to keep it on. Needs lots of reminders. It only is necessary when they're in public or when they're in a crowded situation, such as in a preschool, it should be used. There are preschools who are not making the children wear the masks, which is why my grandson had the cold symptoms, because he caught it from his sister who was in preschool where they're not requiring masks. And I think it's really about spread to others who are vulnerable. I think the requirement on an airplane is more important than the requirement in a mall. If you've got your kid in a stroller and you're in the grocery store and they're not running up and down the aisles touching things, they're less likely to spread it to others. So I do think there are alternatives if you can't keep the mask on the child. But that 2 to 3 year old age range is actually typically the age that's infecting everybody with RSV and with rotavirus and norovirus and whatever. Okay, so your phone's US based. I still don't know how they kept you from using it out of the country. Be safe. Do you think a 2 to 3 year old will have a greater immunity by being around the general population versus staying home? Well, they'll definitely have more exposure. So they will get sick more, and then they will have more immunity, but it's at the cost of being sick. So you have to recognize that as well. And you were vaccinated before your 2 courses of COVID, and I'm so sorry. Get your booster, a month later. So that answers that. So vaccines do prevent one from getting COVID the majority of the time, but it doesn't prevent all infection. And Omicron is the best variant so far. Delta was pretty good too at causing an infection in people who are vaccinated. And those who are vaccinated do get fewer symptoms. But if I could go back to that slide about hospitalizations in the vaccinated and the unvaccinated, that's actually the answer to that question. So if you go back to that slide, the one with the Omicron wave, that one, that. Go back. Oh, no, you already did. I'm sorry. Okay. Oh, wait, no, that's not the one. It's the one that goes into February. Can you find that one? See, yeah. Okay, mine now it's come up on mine. So, so you see there's this blip here. These are hospitalizations. So even people who are vaccinated, some of them go into the hospital, mostly because they have immune compromise. But you can see what the Omicron wave did to the unvaccinated and what it did to the vaccinated. Still, there was some vaccinated people still got sick enough to go in the hospital more than before. The rate of death was actually, this chart doesn't show the rate of death, but the rate of death was still actually pretty low among the vaccinated, really low among the vaccinated. So vaccines do make your symptoms less as well as preventing infection. And so, the vaccine is preventing whatever the difference between the top curve and the bottom curve is, and then making milder lessening the risk of hospitalization. But Omicron did a pretty good job of infecting us anyway, and it's going to depend on the variant.
Okay, Dr. Mazoon, we have time for one last question, and it comes from the chat. It asks about long-term effects of COVID-19 to watch for other than fatigue, body aches, or sleep disruptions.
So there are some long-term cognitive effects or effects on your thinking, on your memory, on your, your processing ability. So that, I think, is, and balance as well. Somebody put brain fog and balance. Those are long-term effects. And so those are really among the more serious ones, because brain fog is not easy to overcome. It takes, a long time to get through that. And some people we don't know how long, because the pandemic's not been around that long, but some people have brain fog 2 years out from their infection. And balance is also very important, because, people who have poor balance tend to fall, and people who fall and break their hip tend to die at higher rates. So yeah, there are a lot of long-term effects, and there are a lot of clinics now trying to do these long COVID, they're having long COVID clinics to try and determine more what some of these effects are and how to deal with them best. It may be that people with brain fog, for example, may need some occupational therapy and, sort of mental exercises, things like that. It's very serious.
Well, thank you so much for this presentation. I definitely am feeling optimistic, but I'm for sure going to keep masking. Definitely. Thank you all for tuning in today. I know we ran over time a little bit, but if you do have questions or comments, you can always send those to us at healtheducator@thewomensfund.org. We also have a link here to a survey that I will be sending out in a follow-up email. Dr. Mazoon always does such a wonderful job with her presentations. So please provide some feedback. Let us know what you liked, what topics you're interested in hearing from the Women's Fund. And then I have our social media pages and our website if you're interested in seeing what we have coming up. We do have a presentation over nutrition later this month as a part of our health and wellness awareness series. And our next lecture series, which will be the last for the semester, is April 12th, and it will be over financial health and wellness. So you'll definitely want to sign up for those presentations. And then lastly, just because I have your attention, the Women's Fund is looking for volunteers to help us out with our art project at the Bayou City Art Festival. It will be later this month, the 25th through the 27th. We have shifts available for all 3 dates. If you're interested, we do have a link up on our website where you can sign up. I put the QR code here as well. We would definitely appreciate if you could help us out and volunteer with us at the festival. That is all I have for you. Again, thank you for taking the time to be here, and I hope you all have a great rest of your day. Bye.